Dr. Meldon Kahan, you've heard him referenced earlier today. He's an associate professor in the Department of Family Medicine at U of T and the medical director of substance use services here at Women's. He now leads the Medify project, and I think we're going to hear some more about that right now. Thank you.
So I've been in the addiction field since 1984, a long, long time. And it's never been this bad. It's just astonishing what's happening. I talk to patients and they know people who have died. I know patients, some of my patients have died. Everyone in the field is just shocked at what is happening around opiates, but not just opiates, crystal meth and alcohol and other things. And I think that the entire medical profession and the ministry is just scrambling to keep up because we don't know how to respond to this crisis. Part of the problem is that addiction treatments really have no role in the healthcare system. A patient can present to the emergency department with a life-threatening overdose, and that happens every day. At one downtown hospital, they had 42 overdoses in the month of August that were revived. That's just one hospital. Generally speaking, these patients are discharged with nothing. No naloxone, no advice about overdose prevention, no follow-up or referral to an addiction clinic, nothing. And this is really bizarre because there are, in fact, inexpensive, evidence-based, safe treatments out for them. One example is buprenorphine, which I think Tara mentioned. It's an opiate agonist. It's very safe, much safer than methadone. It can be prescribed by any physician. No special training is required. Why aren't patients who are in the emergency department offered, at least, buprenorphine with follow-up for immediate addiction treatment? This is I think it's probably due to only, there's only two possible explanations. One is that the healthcare system sees no responsibility for treating addiction. They're passive observers. They say, oh, isn't it too bad that these people are dying, but it's not our problem. It's not the emergency department, it's not the hospital, and it's not primary care. The second is that we have a really weird addiction treatment system. Where do these patients get treated? One of two places. One are these abstinence-based psychosocial programs, and the other are the methadone clinics. The abstinence-based psychosocial programs don't offer buprenorphine, which is kind of bizarre, I think, but because we know that buprenorphine and methadone work. So if they have physicians, if they're supposed to be healthcare-based, why don't they offer that? The other is the methadone programs. I was kind of listening to a couple of the talks, and here's these people that are working in, Cambridge and other places who are so brave and courageous, who are putting such tremendous amount of work into community-based programs, and they have to, scramble and beg and, for money, volunteer, private donations, the Ministry of Health. Meanwhile, there are methadone doctors who are each making well over $1 million a year. And what are they providing in terms of treatment? They are providing abysmal care. And we know that because the dropout rate for methadone treatment is 50% annually, which is actually very high, because they are making patients come to twice a week, ongoing, to get a script, to hang around the office, to get a script, and to leave a urine drug screen, because that's how they get paid, is through OHIP. So what does that mean to the patient? Well, how can they live? In this way? How can they go to work? How can they look after a family? What about the costs involved and the time involved in transportation? In Indigenous communities, there are some Indigenous communities where the bands themselves have to pay a fortune to bus patients into some nearby community every day so that they can get their methadone. This is not good medicine, it's not safe, and it's leading to this kind of treatment dropout. In the meantime, primary care doctors, what's happening with them? Well, some of them are continuing to prescribe high doses of opiates, and I think one of the speakers alluded to, the rest are freaking out because of the college investigations and so on, so they're cutting patients off. they're abruptly tapering and cutting them off. And what does that mean? They go into withdrawal and they go to the street and they get illicit drugs laced or contaminated with illicit fentanyl. So you have this paradox of opiate prescribing declining while overdose deaths are going up. So we have just a system that's out of control and is not meeting people's demands, and it could, in theory, be fixed with some simple and not expensive. You don't have to build a whole bunch of new clinics. You just have to reorganize how people are working and get the healthcare system to accept responsibility and stop these kind of empires like the methadone clinics and so on. So this is what we're trying to do with Project Medify. Oh, okay. Basically, what we want to do is have people treated the same way they would be treated for any other serious medical or psychiatric condition. So if they present to the hospital with, heart failure or heart attack or pneumonia, they are seen in the emergency department. They receive treatment for there. If they need to be admitted, they are. And then if they need specialist care as an outpatient, they're referred to some specialty clinic. And once they're stable, they go to primary care. That doesn't happen with addiction. Like I say, you can present with suicidal ideation or trauma or sepsis or psychosis, and that's it. I mean, they'll fix you up, but then you're going out with no link to addiction treatment. So we feel that anybody should be able to get into addiction treatment right from primary care, the ED or hospital, psychiatry, withdrawal management, etc. And one link that we're proposing is what we call a rapid access addiction medicine clinic. This is basically a low barrier care. By the way, we talked a lot about stigma and health equity. What's happening in the system we have now is that there's the people that are most marginalized, that have the least resources, are also getting the worst care, because they're the ones that are being managed in the withdrawal management centers and the shelters and the methadone clinics and so on, whilst the people who can afford it are able to get the medications they need and are able to navigate the system. And one kind of incredible, egregious example is Indigenous communities that are basically beholden or almost like controlled by these methadone clinics, and they need to be able to break away from them. So how does a rapid access clinic work? The idea is that patients simply, you have an office, you have specified time, patients can come without an appointment where they will receive immediate treatment. That may involve, often does involve medications, buprenorphine if they're opiate addicted, or naltrexone and acamprosate if they are alcohol addicted. And they will receive an assessment by both a nurse and a therapist who is maybe a case manager or a nurse or a social worker. And from there, they are followed for a period of time and referred to community agencies, self-help groups like Alcoholics Anonymous, and so on, maybe psychiatry if that's necessary. And ultimately, the idea is that they're sent back to primary care. So this is the idea, totally low barrier. The RAM clinics are located in or near the hospital or the downtown core or the withdrawal management centers. And the ultimate goal is to send the patients back to primary care. That's where they receive the most comprehensive, safest care, and also the most cost-effective care. So what this would mean in terms of the hospital is for patients with opiate use disorder that they are given buprenorphine right on site, especially if they're in withdrawal. If they're not in withdrawal, they're given a take-home dose for a few days until they can get to a rapid access clinic. They're also given take-home naloxone, and they're given overdose prevention advice and clean needles if that's and if they're using it by injection, and they're advised to go to the next available rapid access clinic for an ongoing buprenorphine prescription. For patients with alcohol use disorder, it means full and complete treatment of alcohol withdrawal. And here's another example of stigma and how the healthcare system feels. It's very routine now for emergency departments to send a patient out before their withdrawal is fully treated. Why? Because they don't want them hanging around the emergency department because it takes several hours. And so they leave in withdrawal, and the relapse rate must be close to 100%, even if they're sent to detox, because they're in withdrawal and they need alcohol to recover that. Sometimes they're given a script for benzodiazepines, which isn't even safe if they have alcohol withdrawal. And what other medical condition could the emergency department say, well, I know that I haven't really treated you, but I don't want you hanging around? Like, never. So this is what we're saying is fully treat withdrawal. That's your obligation. If you're going to give patients a medication, it should be an anti-craving medication with follow-up at a rapid access clinic, because alcohol use disorder is also treatable, and many patients respond well to treatment. So what we're trying to do with hospitals is to talk to them, to educate them, emphasizing that this is their responsibility to treat addiction. We have created these e-modules for use by emergency departments and primary care on alcohol and opiate use disorders. We've written protocols that are on the ED intranet so that they know how to use buprenorphine and know how to treat withdrawal and use naltrexone and so on, cards and pamphlets telling them about rapid access clinics, and reports so that the hospitals can actually dispense take-home naloxone and buprenorphine on site. So for primary care, like I say, this is a mess now. Doctors are getting rid of patients and they're turning to the street, and as a result, patients are dying. What we want is that primary care doctors know how to prescribe opiates safely, they know how to taper safely, and they know how to use buprenorphine. We know that there are clinics that refuse to use buprenorphine, and we're saying, no, you can't do that. I mean, that's just, it's like saying, well, I don't prescribe antipsychotics for psychotic patients, or I don't treat depression. This is something that you have to do. It's especially ironic that, as Tara mentioned, this crisis is, to a large extent, a medical crisis. It was caused by the medical community, listening, kind of being taken in by a slick pharmaceutical advertising campaign, and yet we're not willing to treat it. So for alcohol use disorder, we want doctors to routinely prescribe anti-craving medications when indicated, to follow patients, to provide support, brief advice, and referral to community services, and to manage medical and psychiatric complications. And again, we have e-modules for primary care doctors. We've created a handbook for them. A lot of what we're doing is trying to get doctors to change their practice. And it's probably, it is a good time to do this because doctors are frightened. Nobody is complacent about this anymore, if they ever were. Results to date, we were funded originally by Arctic, which is adopting... Yeah, sorry. That's from health. That's Sarah Clark, who's my colleague, and we have a small team, but Sarah and Kate have done a wonderful job. Sorry. So we had this grant from Arctic, and we opened 7 sites across the province. When I say we opened, I don't mean we actually opened. We just got people in the community to do it. And the one thing about our model is that it was the communities themselves, the people themselves that actually took charge of it. I'm going to really go fast because there's not much time left, but we worked with them. I think we're now, all these sites are sustainable. They don't require additional funding or grants. They're sustainable because OHIP pays for addiction doctors, and the hospitals have lent their support through giving clinic space and letting nurses and case managers be seconded to the site. So that's why they're sustainable. So we're really just reorganizing things rather than... Patients love it because they get individual attention and concern. They're seen immediately, and they're not they're not treated like with contempt. And it's incredible the stories we hear about the things that patients are told. Oh, Cindy, here you are again. You just want Valium and so on and so forth. They're really, it's unbelievable, a kind of attitude that patients get from healthcare providers, but they really feel like they're not getting that with this individual approach that we have here. Healthcare utilization, this is 90 days pre and 90 days post. attendance at the RAM, and this is 6 of the 7 sites we have data for, and we see a marked drop in ED visits in pre versus post, and also a marked drop in emergency department days. And this is a rough estimate of the savings, cost savings, net cost savings from this RAM intervention. So what are the benefits specifically for women? And I think this would apply for any marginalized population. We do provide trauma-informed care. And this is non-stigmatizing. It just names like Center for Addiction and Mental Health can be very stigmatizing for patients, and they don't want to go, and they have to admit that they're addicted. And this is in a general healthcare center. It's a women's college and other RAM clinics. So it's not stigmatizing in that way. They're able to be connected to primary care and psychiatric services, and they're able to build a strong relationship with an individual provider, whether it's the physician or the nurse case manager. So next steps, we're also trying to get it done in Toronto, and we already got one going at Women's College Hospital. We have a phenomenal nurse clinician who is not here today, Irene Jaragi, who's doing so much good work with these patients. And we hope to have a support for a provincial program where we're actually helping to coordinate other rapid access clinics that may get support from their LHIN.